I just know.
Hello, good afternoon, everybody. Welcome again to our Thursday 2 o'clock session. And today, welcome Professor James Neuberger, who's been a hepatologist for about 200 years now, as you can see by looking at him. No, but seriously. Got your questions? If you can put them up in Facebook, Linda and Chris are in the background, and Alan's there, so they're working away and they'll get the questions to me. So how are you, James, today?
I'm fine, thanks. I'm fine. Enjoying the lack of rain.
I heard that it was going to be pretty torrential. Oh no, that was in New South Wales. That was Australia. It's raining here now. Right, we're going to get started. Now, you all know you all got your bare facts, and for those of you who don't have the chart that we handed out with the bare facts, the weight chart for the Urso. Let me see, it's this thing. It's either on our website or going on our website. It's an imperial and it's in metric, and it's the Urso Dose Calculator. We've had a couple of questions about it, James. So the first one, she was saying, they are saying, I'm very confused. The dosage on your chart is different from the dosage recommended in my Urso information on the Urso Folk leaflet. Could you explain why, please? I think you've got the...
Yes, I mean, just to say, it was interesting. Let me just get the copy that was sent. Yeah. This was a woman who says that she's weighing between 9 stone 4 and 9 stone 5 in the evening. And how much should she take? And what's the clarity? Well, just to go back to the beginning and make it clear how things are done. Firstly, the optimal dose of Urso is between 13 to 15 milligrams per kilogram per day.
Yeah.
Now, that dosage is based on a huge number of patient data showing and supported by laboratory work showing that the optimal effect is that. So one minor comment is people vary in their approach to medication, and in so many ways people are individual. But of course you have to get it right and you have to have clear guidance. Now, the other thing that's important is that most of the capsules for Urso don't come in graded doses. They come usually at 250 milligrams or 500 milligrams. There are liquid preparations, there are other capsules, but basically it's 250 or 500. So the first point then is the optimal dose is a range. And I looked on the chart, which I have here, of course, and let me just get the conclusions. The weight at 9 stone 4 pounds is just a shade under 59 kilograms. And if you look on the chart here, 59 kilograms is very much on the border between 750 and 1,000 milligrams a day. Now, clearly somebody, and again, if you look on the chart, somebody who's 9 stone on the nail would get roughly 750 milligrams a day, and somebody 2 or 3 pounds heavier would get 1,000 milligrams a day. And clearly the difference between of those 2 or 3 pounds may be that you can get into your trousers or whatever more easily, but biologically, of course, it's insignificant. So there is a borderline, and if you're taking 750, you're probably getting just a shade under 13 milligrams per kilogram per day, and if you're taking 1,000, well, you're getting over 13 milligrams, but less than 15. So you've got these, if you like, these arbitrary cutoff, which are useful in practice, but don't mean anything biologically. So and what you have to do, obviously, is you could on the chart have had, instead of having a clear cutoff, is you could have shaded areas because it is a spectrum. That makes some scientific sense, but practically it's not very important. So what I would do is, if somebody is on, say, 750, is on that grey borderline area there, sorry, on the borderline there, if on 750 their liver tests have normalized and they're well, I would keep it on that, because that's the lower end of the therapeutic range. If the liver tests are abnormal, then perhaps you'd go up to 1,000 milligrams a day. So you're talking about 3 capsules or 4 capsules a day, and it's not that critical. What we're concerned about from the clinical point of view is making sure you get enough Urso, and whether you get enough depends on A, the dose, but B, how your liver tests have responded. And of course, you also have to take into account the side effects. So I stand by, this is the right, a good chart, but like all these things, you have to interpret them, you have to use your common sense. And what you're trying to do is you're trying to make a spectrum into discrete. So it's rather like saying, for example, you can't drink alcohol till you're 18, whatever, they're probably about 4 in Scotland, but you can't, and to say that it's completely illegal the day before your birthday, but come midnight it's now legal to drink. I mean, that's clearly when you put it like that, it's illogical, but you need to have the cutoffs. And I think that, I hope, explains the variation in what we've said. But I do stand, we put a lot of people have put work into this. We've had it externally validated. I do stand by it. But our key thing is to say, are you getting enough Urso, rather than are you getting too much?
Yeah, interesting. Those of you out there know me quite well, and I've lost quite a substantial amount of weight. So I had the other side. I said to my consultant, shall I take less? He says, no. He says, you might put it back on again. So that was that. So he wasn't fussy about me taking too much. So that was really interesting, James. Thank you. It was really, really helpful. But we have another question saying, can you alter your dose yourself, or do you need the doctor to okay it? That's a good question, actually.
The answer to both parts is yes. Of course, you're autonomous. It's your body, your health, your liver condition, and you must take ownership of it. And doctors are there to advise you. They're not there to tell you what to do. But it is wise not to change things on your own, because there may be very good reasons why you're on the dose that is recommended. But the key thing is, if you're not certain, ask. If you're on the inappropriate dose, too much or too little indeed, then that can be remedied. If you are on the right dose for you, but it's not the recommended dose, then you need to be reassured that what you're getting is the optimal treatment. So my advice is, don't change things without consulting your specialist. But of course, you have the right to, and use your common sense. But your doctors need to know what you're taking. And if for any reason you decide you don't want to take the recommended dose, let the doctors know. Let them know the reasons why. And you don't have to give the reasons, but it helps to understand it. But tell them, and at least then the records will be correct. If you're taking less than is prescribed, then it stops build-up of supplies and wasting NHS money. So be open, be transparent, and have no reservations about querying your dose with your healthcare professional.
Yeah, no, I think that's it. Don't be afraid to ask, and keep an eye on your weight. I know some people have had difficulty during COVID, So yeah, as James says, you take ownership. And there's another good question, which has been covered before. Is it okay to start off taking Urso slowly and build up the dose over a couple of weeks? I want to try and avoid as many side effects as possible. I wondered if this helped your system get used to it.
I normally recommend people do start off at a low dose and build it up.
Yeah.
Whether that does reduce the risk of side effects, I don't know. I think it's important to remember that most people, when they're diagnosed with PBC and offered treatment, have had the condition for many years. So there's no great urgency in starting treatment. You know, you probably had it for 10 years, 5 years, whatever. And so if you wait and build up the dose over 2 or 3 weeks, that's not going to affect things to any extent. So I think build it up is sensible. If you're getting side effects, then you can slow down. But I think to start off at a low dose, a lower dose, and build it up to the therapeutic dose over 2 or 3 weeks is a sensible thing. Let's say whether it makes a huge difference, I don't know, but that's what I practice, and I think what many of my colleagues will do as well.
And given you've had hundreds of years experience, maybe we should take that on board then, huh?
You think it's about time you learnt then, wouldn't you?
But you know, Urso has only been licensed since 1996, I think, because when I was first diagnosed, there was nothing. So feel jolly lucky to have it. Right, so next question. So a wee bit background. I've been in pain since last year. My whole body aches, so I'm sorry about that. I cannot walk properly in the morning because of leg and foot pain. That looks like singular. My hands are swollen. My hand goes into painful spasm. I also have neck, shoulder, and back pain. My immunoglobulins are raised too. I'm on 1,500 of Urso per day. My mum died of scleroderma, and I'm terrified it could be this. Any suggestions?
Yes, I'm sorry to hear about the symptoms, obviously. And worry is a huge leaden weight on people. And the best way to resolve the worry is to get a clear answer.
Yeah.
Scleroderma, as you'll know, can be a relatively mild condition, but it can be very severe and gives rise to symptoms. I'm not a rheumatologist, but to me, your symptoms don't sound classical that of scleroderma, but obviously with the family history, I wouldn't discount it. I think what you need to do is you need to, first of all, get some blood tests. There are some antibodies that are more associated with scleroderma than with other conditions, and that may help. But do be aware that there's some overlap of antibodies, so that may point you in or may give you misleading. But things like the anti-centromere antibody, for example, in scleroderma is, I believe, more specific, and it's not associated with PBC. The other thing to do is to go to a rheumatologist or a dermatologist and get a definitive answer. If it is scleroderma, then you can stop worrying about it and start thinking about how you deal with it. If it's not scleroderma, you can relax and move on to something else to worry about. But don't stay worrying about it. Go and get a definitive answer, and probably a rheumatologist or a dermatologist is the best person to allay your risks, your concerns. And if you're getting joint pains and so on, then a rheumatologist perhaps rather than a dermatologist. But don't just stay home and worry. That's the
no, absolutely not. And also, you know, depending on what your various specialists have advised you, you know, maybe ultimately a good physio, all physios are good, but a physiotherapist might be able to help you as well. Don't rule them out. As I keep telling people every week, my physiotherapist tells me doctors save lives and physios make it worthwhile. And yes, her husband is a doctor. So don't rule that out. But yeah, it's important you get these tests done and be honest with your doctor about the scleroderma as well. My cousin lived and died. She died of old age, very old age. and she had it. And as James says, it's not necessarily severe in everyone that gets it. So I hope that helps. If not, please feel free to give me a ring. That the office will put you through to me. Right, James, if platelets are over 200, does that mean you don't have cirrhosis? And would that mean you don't need an ultrasound?
If you have, right, in cirrhosis, in people with cirrhosis, you usually, not always, get an enlarged spleen. And an enlarged spleen from any cause can result in low platelets and indeed low white cells and low red cells because it acts a bit like a sponge. So one of the features you see in cirrhosis is low platelets. And one of the markers for cirrhosis is called the APRI, which is the ratio of platelets to other blood markers. These are not specific. And whilst a low platelet count is often suggestive of cirrhosis, a platelet count of 200, which is for many labs at sort of the lower end of the normal range, doesn't exclude cirrhosis. So it means you haven't. Now, the other point I would say is that cirrhosis is not an all or none phenomenon. You don't say one day I don't have cirrhosis and the next day you do. It's a process. It's fibrosis, essentially, with various knobs and whistles on, but it's a process, and it's rather like saying, am I tall? The extremes, but in between. So platelet count of 200 doesn't exclude cirrhosis, but it makes advanced cirrhosis less likely. Having cirrhosis doesn't necessarily, as I say, rather like we were talking about the doses where you're making artificial cutoff. Again, cirrhosis is the same. And if you take, for example, a liver from somebody with PBC that's removed at transplant, you can do a biopsy in one part that'll show very advanced cirrhosis and biopsy another area which shows mild fibrosis. So these things are patchy. And I think a scan is an ultrasound scan is suggestive of cirrhosis but not diagnostic. A fibroscan is more specific for cirrhosis. The higher your score, the more likely you are to have advanced fibrosis. So why does it matters to know whether you have cirrhosis, because cirrhosis gives rise to potential complications like portal hypertension and varices, and you need to be screened for that to stop you getting the complications. So the fact that platelet count is 200 is good. It's better to have 200 than 100. It doesn't exclude cirrhosis, and that in itself, I think, doesn't stop the benefits of having a scan of some sort from time to time. Okay.
Thank you, James. Okay. So in October 21, I received a letter from my consultant after a face-to-face meeting. The CT scan I had showed the common bile duct was dilated. Radiologist recommended an MRCP to study the bile ducts. No action was taken after he consulted with a colleague. In the letter I received, he told my doctor that he had booked me for a scan and face-to-face appointment in January 2022. After many phone calls, the first two I was told that I wasn't even on the list. I'm now being told that the waiting time is 3 to 4 months. I broke my hip in May, and after I was discharged, I had horrendous pains with nausea and loss of appetite. I lost half a stone. I was told that I probably passed the stone. I feel as though I'm being brushed aside. Is it my age? I'm 78. Any advice as to what else I can do will be greatly appreciated. Poor thing. You're not too old. 78's young.
Yes. 78 is no. I mean, to brush people off because of age is not only unacceptable medically but illegal. And I don't think they would do that. I mean, hospitals are under a lot of pressure because of COVID. It's had two impacts at the moment. One is it slows down the processing of people through investigations, and also when isolation was required, it meant that there was significant staff shortages. So if you're unhappy with the way things are going with your treatment, the simple and straightforward way and appropriate way is to contact your doctor, contact them and explain your problem and ask them the simple questions you want asked. Whether you do that by email, by phoning, or by letter is up to you. But I think if you're not happy or if you have concerns, then raise them.
Yeah.
No healthcare professional wants to provide a second-class service. No healthcare professional wants their patients to be dissatisfied. So just write and ask. It sounds as though if you've had a stone that's passed, or the stone's in the gallbladder, which is maybe best left alone depending on your clinical situation. But if you're feeling neglected, then raise that with them. And if you are being neglected, it can be corrected. And if you're not being neglected, you can be reassured. But don't accept age. That shouldn't be the case. And I hope it isn't the case.
Yeah. Okay. Thank you, James. And it's sad when you get a bit older, when people begin to feel like that, isn't it? Okay, so what might cause occasional flare-ups in ALP up to around 300 in a patient who's otherwise generally well and has an ALP of less than 1.67 ULN? Does this always indicate there may be other issue at play, or is it just occur as part of the normal course of PBC in an Urso responder?
I think it's a combination of all three. I think ULN, just for those who, if anyone's listening, is the upper limit of normal.
Right.
So different laboratories have different normal ranges, depending partly on their population, depending on partly on their methodologies they use. And there is a normal variation of alkaline phosphatase, normal ranges. These are people without PBC. So, for example, it's very high when you're young, it falls, goes up during a growth spurt, falls again, goes up if you're pregnant, for example. So there's a difference in the normal ranges, therefore the upper limit of normal between men and women, and between some ethnic groups, there are differences. So you've got to sort of interpret levels with caution. The second point is that laboratories, when they measure any chemical in the blood, there's a variation. So if you take the same sample and measure it 3 or 4 times, you'll get slightly different answers. You may get 115 one day and 120 the next, 110 the next. So these things are not as precise as one would like to think, and that's why we always say look at trends rather than individual points. So you do get normal variation, which I suspect is partly the individual just has a normal fluctuation. These are not held constant. There'll be a variation because of the way samples are handled, the speed in which they get to the laboratory, the speed in which they're tested, because that again will affect some blood test results. Then there's machine errors. So there's a lot of reason to expect a degree of fluctuation. And as an aside, for example, just to illustrate this, when people, there was a time in some countries where clinical trials were done and doctors were personally reimbursed, and doctors I'm ashamed to say, used to make up data. And rather like the Inland Revenue, the companies set up algorithms. So if there was too much variation, they'd suspect there might be a bit of dishonesty going on. And equally, if there was too little variation, it would raise a flag. It wouldn't mean there was anything wrong. And it's the same for Inland Revenue. They know that, say, for chief executive, that the rates of pay will be within this range, and if it goes outside it, it doesn't mean there's any hocus pocus, but it means it's worth investigating. So what I'm saying is you do expect a little bit of variation. If you get significant changes, as I say, depending on the clinical scenario, you may want to investigate then and there, or more often, if there's no clinical change, you may just want to repeat it and make sure that change is significant. It may be that, for example, some of the variation in ALK Phos comes from the bowel. If you have a bowel problem, a bit of infection, that may push up the ALK Phos, or you've had a bit of bone vitamin D deficiency, for example. So I wouldn't be too hung up on the one-off. I'd look at the trend. But if you get a significant departure, then you do want to check, because sometimes, for example, there's a very significant cause. And with ALK Phos, of course, it may be liver, it may be biliary, it may be none of the above.
Yeah.
But don't let it go unchecked.
Okay, well, that leads me to the next question. Is it normal for the ALT to remain moderately elevated in PBC?
It's ideally you want it to normalize on treatment.
Yeah.
And as you know, or many people would know, there is a spectrum of inflammation of the liver, which at the extreme end is called overlap syndrome. So if the ALT does remain elevated, I think you need to discuss with your clinician about the treatment. Are you getting enough Urso? Should other treatments be considered? Again, it depends how high it is. The normal level's up to about 42. You know, if it's over 100, certainly have that discussion with your doctors, and interpret that in the light of the rest of your clinical symptoms and your treatment.
Okay, so does Professor Neuberger know of any cases where PBC patient has skin issues? Now, in particular, blisters and mouth ulcers. So I'm assuming they mean blisters on the skin, and most, as I said, skin issues, and then mouth ulcers.
Yes, there are a number of skin conditions, which include mouth ulcers, which are associated with PBC. Of course, you can get conditions that are unrelated to PBC, and you can get some skin conditions that are associated with the consequences, for example, vitamin or mineral malabsorption. So again, as we keep on saying, don't attribute all your symptoms to PBC. The first thing to do is to get your GP, who's often a very good dermatologist, to look at your skin problems and get a diagnosis, and then you can attribute it to whatever, but get the right treatment. So PBC in itself, apart from the excoriations from itching and maybe the pigmentation that people get over the face and upper body particularly, those are the ones that are associated with PBC, but other caused by PBC, if you will, but other conditions may be associated with PBC or its consequences. So get a diagnosis, get a treatment for it, but most of the skin conditions associated with PBC will not be affected by the treatment for PBC.
Yeah.
Is that so? Get a diagnosis and get the right treatment. Often it's something trivial. It may be sort of allergies, it may be a rash, maybe eczema, but get somebody to see it. And even something like eczema, which is not serious in the vast majority of cases, can cause great symptoms and discomfort.
Okay. This is a very, very interesting one. I actually spoke to this lady the other evening. I'd never heard of something. She was absolutely fascinating. So just a bit of background here, and then her question is actually about vaccination. She has post-polio syndrome, as well as an underactive thyroid, a high parathyroid in addition to PBC, which gives me major respiratory problems. I have a BiPAP ventilation and oxygen at night and oxygen to walk. So she goes on to say immunizations. I was told I require hepatitis and pneumonia plus a fourth COVID vaccination every year, but nothing more has been mentioned and it wasn't in the follow-up letter. Should I speak to my consultant with regards to the vaccines? Now this is in England. This is England.
Right. Again, without the details, hepatitis vaccination is a good thing for everyone, and hepatitis A, hepatitis B, they're very good and safe vaccines for them. Hepatitis A, particularly as you get older, can be a severe disease and can cause liver failure, although it's extremely rare, but the risks of hepatitis A increase with age. But it's still usually a minor condition that resolves and leaves no legacy. Hepatitis B is a little bit more serious. Some people have an acute hepatitis B. It's less common as you get older. As you get older, you're more likely to get chronic hepatitis B, and that, if untreated, can result in cirrhosis and liver cancer. There isn't a cure for hepatitis B, but there is a treatment, but it's a treatment rather like with PBC. It's a lifelong treatment with medication. So vaccination is simple and safe, and all, certainly doctors and I suspect nurses, have to have hepatitis B vaccination if they're doing invasive procedures. With COVID, whether you have the fourth vaccine or not, I would ask either your GP whether it's appropriate, whether you come under the inclusion criteria.
Well, she's been told she has, but it's not in her follow-up letter. So who does she go to find out? I
would go either to her specialist or maybe just the vaccination centre, because again, I'm not quite sure what the current situation is, but a lot of areas have roll-up vaccination. You just turn up and they will tell you, and if you come with some evidence of your history, they will have your vaccination records on file, obviously. And if you're eligible and it's appropriate, they can give you the vaccination then and there. So it's maybe best to ask the vaccine centre.
She's saying, well, I don't think this lady actually gets out very much. There's nothing's been mentioned. It wasn't in her follow-up letter. So whoever, I think, has written that letter to her, I think she needs to go back to that doctor, specialist, whoever. Would that be a fair thing to say?
Either that or go back to or go to the vaccination centres, because they will know, which I mean, the rules are changing as we get more knowledge and more experience and even greater confidence in the safety of the vaccines and their efficacy. So you could go to the vaccination centre and or get somebody to go, and with the medical details, the drugs, the medication, and say, is this appropriate? In which case it is, then you can make an appointment and just get it done.
Yeah, Jen's saying, Jen's a volunteer, one of our members, which is a volunteer at the vaccination centre. If there's any help, our vaccine centre, and I know that's in London, all forced vaccines are being arranged via the GP. So there you are. So there's some additional information there. So why not phone the GP surgery and let them help you chase it up if you can. Okay, so it's an interesting question here. As a majority of PBC cases are identified in women in their 40s and 50s, I suspect a lot of women would tell you they had symptoms for many, many years before diagnosis. Do you believe there's a link to the reduction of the production of hormones around this time in a woman's life and a diagnosis of PBC? I have symptoms of fatigue and itching, which have all appeared around the same time, just before my diagnosis. I am now about to start HRT. Is there a link, either anecdotally, or is there, or will there be any studies on this?
People have looked a lot at the sex hormone impact of PBC, the possible impact. And for example, then there is clearly some impact because we see PBC presenting often in pregnant women. But there is no clear association, a direct association. There may be, and one of the issues, of course, is with many people, the symptoms of PBC are very non-specific. And that's partly why people have a delayed diagnosis in some cases, because there are many causes of people feeling tired, washed out, brain fog, and so on. And PBC is one of the, and although brain fog is very common in PBC, there are a lot of other causes of brain fog as well as PBC. So we don't know if it's because of the age, it's because of the hormones, it's because of the diagnostic. So people have wondered, because I think there are three classic key things that point to the etiology of PBC. One is it affects women 9 times out of 10. Why is that? Secondly, it doesn't seem to occur in children. Why not? Most other autoimmune diseases, autoimmune hepatitis, thyroid disease, pernicious anemia, celiac, etc., all occur in children. PBC doesn't for some reason. The third thing is that you have the antimitochondrial antibody. That seems to be specific to PBC. What does that tell us about the mechanism or the cause? We haven't worked out really. And finally, it recurs after transplantation. So why is that? So you give somebody a liver without PBC and they get PBC in the new liver. Is that an infectious agent? So there are all those issues, as a sex or gender, whichever, I'm not sure which is the right term now, but sex hormones are clearly associated with PBC, but how that impacts on the development of PBC, the diagnosis of PBC, the progression of PBC, we don't really know. There's a lot of work being done, but nobody's been able to piece it all together. And I think once we have once we know the cause of PBC, everything will
fit into place.
Fit into place.
Okay. Is there a link between PBC, AIH, which is autoimmune hepatitis, and ketones in the urine?
Ketones in the urine can be caused by many factors. We most commonly see them in starvation, in hunger, and in diabetes. So it depends on the clinical situation. It depends on other conditions. It depends on treatment. So if somebody said they had ketones, I want to know how many ketones, what their other conditions were like, as to whether I thought this was worth investigating or not. It may be something that's mild and of no significance if it's low levels and transient, or if there are other conditions. So raise it with your doctor, but be more specific. And the question is, why were you looking for ketones? Was it a routine urine test?
Yeah.
Was it because you're not well? Was it because you've got other urinary tract problems or whatever? Don't ignore it, but I wouldn't put it down to the PBC
Okay.
in general, but without knowing more, I wouldn't exclude it entirely.
Yeah. Do you know, we do these questions, James, and they come in all shapes and forms, and they're amazing. But sometimes you read something, and you know, you just feel. Well, I feel quite lucky that I've had a reasonably good journey with PBC. So this person says they were diagnosed in 1998, but they don't have the antibody. Had an ERCP in the year 2000 because the doctor I saw, he didn't think I had PBC. The procedure went wrong and I ended up with acute pancreatitis. Fast forward 21 years, my pancreas is completely shriveled up. Last year I had internal bleeding, sent to the hospital, but they did not investigate. I have developed problems with antibiotics now, cannot tolerate lansoprazole.
Lansoprazole, yeah.
My itch has got worse since Christmas, and I feel like I have a tight band around my waist on my right side. Feels like something is digging into my ribs. Blood's checked, and bilirubin has been 6 for years. It's now 14. Amylase is now 130. Creatine 129. I have chronic kidney disease, and I take 1 times 250 milligram of Urso per day for 22 years. What does this indicate?
Confusion, I think, is the answer.
Yeah.
A number of things. About 5 to 10% of people with PBC don't have antimitochondrial antibodies detectable by the standard techniques.
Yeah.
And they run a course of PBC identical to those with classical AMA positive PBC. When you get somebody with AMA negative PBC, you always have to ask yourself, is that the correct diagnosis? And we've learned a lot about other conditions which can mimic AMA negative PBC. One is sclerosing cholangitis. And although years ago, we used to diagnose that with ERCP, and nowadays, of course, MRI is a good way. It's not as sensitive as ERCP, but it's safer, and the complications of pancreatic inflammation, pancreatitis, is obviously avoided, and I'm sorry to hear about that complication.
Yeah.
The other condition that one always wonders about is a recently recognized condition called IgG4 cholangitis,
Yeah.
or some people call it, and there's also autoimmune pancreatitis.
Yeah.
So when I see a patient in clinic, or when I used to do clinics, who was AMA negative, I particularly diagnosed 20, 30 years ago, I always think, well, am I sure this is PBC? Because autoimmune cholangitis, for example, is helped by steroids rather than Urso. And it's easy enough to check. I would also stress that people on Urso, the AMA can become, usually falls in theta and may become negative. So the fact that you're on Urso and AMA negative now doesn't mean you don't have true PBC.
Yeah.
You can also, again, before treatment, you can look at the other PBC autoantibodies, the GP210 and the SP100, for example, which are also specific for PBC, but not AMA. Lansoprazole is not an antibiotic. It's a drug you give for peptic ulcers, you give for it's like omeprazole, it's a proton pump inhibitor. And if you can't tolerate that, but there are similar but different treatments for it. The symptoms you're getting is that an amylase of 120 is towards the upper limit normal. It's not diagnostic of acute pancreatitis.
130.
130. I mean, normally with acute pancreatitis, you get very high levels, and there are other ways you would investigate for chronic pancreatitis, which certainly can be a very painful condition and one that's really quite challenging to treat. So if you're getting symptoms, then have them tell your doctor and get them investigated so that you know, if this might be a pancreas problem, then you can image the pancreas, you can do pancreatic function tests, and so on. And there are many causes of pancreatic damage, and there is a weak, if I remember rightly, a weak association between autoimmune pancreatitis and PBC, like there is with other autoimmune diseases and PBC. So get it investigated. The renal impairment, depending on your age, mild renal impairment increases with advancing years. But again, one needs the context of that to know whether it needs testing or just monitoring.
Okay, so we go on. Going for DEXA scan and a liver biopsy. I don't know why you need a liver biopsy, but anyway, make sure you do ask why. Fingers very swollen, been on Urso for 5 years, 250 3 times a day, now 500 twice a day. LFT's high, consultant talking about OCA, or visit Cambridge. She wonders if overlap with PBC and autoimmune hepatitis. Well, that's what the liver biopsy would show up, wouldn't it?
Yeah, I mean, the DEXA scan is basically an X-ray scan to see if there's evidence of osteoporosis. Osteoporosis increases with age, increases in women, is increased with liver disease. And if you do have osteoporosis, then there are some treatments that will reduce the risk of fractures and bone pain. So the DEXA scan is a sensible thing to do in PBC, irrespective of anything. And if your doctors are thinking of overlap syndrome and maybe discussing with you steroids, again, a DEXA scan is particularly helpful because steroids greatly increase the risk of osteoporosis. And therefore the risk-benefit balance will change. The biopsy, again, as Collette said, ask why the biopsy, but it is reasonable to do a biopsy if you're thinking, is there a lot of inflammation in the liver? And would give steroids. I think if you're not having an optimal response to a therapeutic dose of Urso, the next stage might be OCA addition rather than steroids at this case. That would be my preference, but again, I don't know all the clinical details. Whether you want, I mean, Cambridge have a very good liver unit. It's not quite as good as Birmingham, but it's getting there.
No bias, no spin, no bias.
Well, George Mells, who's one of the luminaries, he was trained in Birmingham, so he must be.
Oh, was he?
He spent some time in Birmingham. No, but it depends. I think if it never does any harm to have a second opinion, and if you're concerned, and it depends how specialist your own doctor is, whether you want a second opinion. But remember, you do have a right to a second opinion, but I would stick, ask your doctor why the liver biopsy, whether you'd be a candidate for OCA rather than steroids. But knowing how to deal with the overlap syndrome is something we've talked about and others have talked about many times. I, as you know, don't believe that it's an overlap syndrome. I think it's just part of the spectrum of PBC. And my preference would be to try adding ochre in general. But again, for your particular case, I don't know the details and wouldn't like to comment. But if you're specialist, the hospital doctor you're seeing is a specialist in PBC, you can talk to them about it. If you're concerned, then you could always go to Cambridge for a second opinion.
Yeah. And why not? If that's the right and that's the system, there'd be no harm. I don't see any doctor would be offended, would you, James?
Yes, they probably would be offended because it means that you haven't got the full confidence of your own patient. But your doctors being offended is not the prime purpose. I think the issue predominantly, of course, from the health professional side is if you're seeing people in multiple units, you're building up the workload and you're putting more pressure on the system.
Yeah.
And so if you've got 10 appointments, if you're somebody basically having 2 appointments, one person's going to miss out. So, but the other thing is you could write to the, or your specialist could write to Cambridge, to George Mells or whoever, there's some very good other ones as well, and ask for advice without necessarily going to see them. But
Okay, so we've got one on the screen here, James, from Margaret. I am soon to be scanned again, prominent duct pancreas. I know possible outcomes, but could this be PBC related? I also have dilated bile ducts, feel okay otherwise.
One of the problems with investigating people is you pick up issues which you rather wish you didn't. Because in the early days of ultrasound, for example, which goes back only about 30 odd years, which to me certainly is like yesterday, when I was when I had hair and so on.
I remember those days.
People picked up a lot of cysts and a lot of things in the liver, and a lot of people had a lot of unnecessary investigations. And the thing about things like a prominent duct, the pancreatic duct, means it's slightly more prominent than usual. But it doesn't mean there's anything wrong there. It's so if, for example, let's go back to height, that if you measured people's height, so 200 healthy people, you'd find a distribution that most people are in the middle, some people at one extreme and others at the other. It doesn't mean there's anything wrong if you're at the extreme, but the normal ranges would be, they're usually taken to cover 95% of the population. So that's how they measure the normal hemoglobin, the normal alk phos, etc., etc. So you'll have 5% of normal people who are outside the range, but they're normal. And it's the same with a pancreatic duct. It means it's more prominent. So what they're doing is just the right thing, is they're monitoring it. If it's staying slightly prominent, not getting bigger, then the best thing is to leave well alone. Because that's what you are. You just have to have a prominent duct, like some people have a prominent nose or prominent ears, or what have you. If, on the other hand, it's getting more prominent, it's getting bigger, then you'd say, is something going on, stone or what have you. When you do these scans, you pick up these abnormalities and you think, oh, bother it, or something more colourful. And you don't want to ignore it, but you just check it up, make sure it's not changing. And that's, for example, what we do with many cysts found on ultrasound. You think they're benign, there's nothing serious, but you just want to be absolutely sure to make sure they're not changing over time before you can reassure. And the dilated duct, again, that could be a sign of something at the pancreatic head, but the most, if you're staying well and everything is normal, then just to keep an eye on things is sensible. so that the worry or the problem for the doctors is you have to balance, do I just assume this is the normal variation, or do I follow it up knowing that I'm going to worry the patient?
Yeah.
And most people will say, we're going to worry the patient and have them safe. We're aware that, by not getting a clean bill of health, you're causing anxieties, and that's just the way it is, I'm afraid. You can't have it both ways.
Yeah, we talk about this, living with PBC, James, and you and I have talked about this many times. It's not just all the itch and the tiredness. It's the fact we have to attend hospitals, and we're asked to get blood tests. So you think to yourself, oh God, what are they going to say this time? When's my endoscopy due? Oh geez, I've got to go through that, and all these sorts of things. And it's a lifelong deal, So it's lovely that people can chat to each other and give each other assurance, and doctors like yourself will come on board and explain all these things, which is fantastic. You'll be pleased to hear you've finished within time. That's all the questions. I would say to everybody, I'm going to have a chat to James, one of our doctors who used to work in Birmingham's now in Canada, and he sent me an email. A lot of you have been asking about urinary tract infections, etc. So that's something on my list to do with James and Professor Jones and George Mills. I'll drop them an email. So I am on that for those that have been asking about it. I would also want to thank everybody in the background, because us beauties, us pretty ones, get the front seat. We've got lots of people working in the background. That's why they work in the background. They're not as pretty as us. And so I want to thank you to them. And I want to say to you, our members, so I'm going to sneeze, do keep the donations coming in. They've slowed down hugely since I've stopped mentioning them on a Thursday. We don't get any government funding. We're like every charity, it's a struggle. We've got lots and lots of questionnaires going on, surveys, etc. We're keen to work with researchers and farmers, but we need your help to do that. We need us to give a bit of your time. And if you can, go onto our website and make a small donation, we'd be really, really grateful. So, Chris, Alan, Linda, thank you. Sorry,
if you can't make a small donation, you can always make a large one.
A large one. Oh, there you go. That's you as well, Chris. You just walked in. Get the wallet out. So thank you very much, team, to make this happen. It's brilliant. We're back next Thursday with Dr. Can't Remember. Is it Professor Jones next Thursday? Alan?
Dave Jones next week, yeah.
So we're in for a marathon. He's a lot slower.
Get the questions in.
Yeah, which doesn't help my trapped nerve. Thank you very much.
Okay, thanks.
Thanks, everybody.
Have a good week. Thank you.
Thanks, James. Thanks very much.
Bye.
Bye just now.
Bye.